All right, everyone, welcome to Speak. Thank you for being here today. We were super excited to welcome Dr. Lina Patel. She's going to be talking about mental health with individuals with Down syndrome. We've had her present several times, and she always does an amazing job and offers so much information. So we're so thankful to have her today. If you will just continue to stay muted, we will have time for questions at the end. So thank you so much for being here.
Okay. Hello, everyone. Thank you so much for joining me over your lunch hour to be able to hear me talk a little bit about mental health and Down syndrome today. I will hopefully we don't have any technical difficulties. Um, so I think it's important to kind of know the context. As Whitney said, I have spoken to this group before, but I always like to be able to share the different aspects of work that I get to do for people with Down syndrome, which kind of helps with being able to collectively come up with some of the knowledge that I've been fortunate enough to gain over the years. So the first thing is that I do research with the Cernic Institute for Down Syndrome. Again, all Down syndrome specific related research. We have several clinical trials that we have completed or are just getting ready to launch. And my role, I should say, at the Cernic Institute is really to help with the neurodevelopmental assessment part of the clinical trials, and to really support, our participants being able to successfully, and, without distress, participate in our research. And then I consult with Global Down Syndrome Foundation and try to help support them with, the advocacy that they do to try to provide educational opportunities, to be able to, do speaking on topics that I am knowledgeable in. And then I used to actually work for the C Center for Down syndrome. I work at Children's Hospital Colorado, still seeing patients with Down syndrome. But I, work very, very closely with the C Center, but am able to provide telehealth, to rural and remote parts of the state of Colorado, to be able to give access to folks who might not be able to drive to where the C Center actually is. And then I also actually have started working with some of the adults from the Adult Down Syndrome Clinic, specifically on help with things like desensitization to wearing medical equipment, and being able to kind of provide some support around mental health concerns, but a little more limited given that I am a pediatric provider. So, what are the types of referrals that I typically get for psychology? I get referrals for things like toilet training, desensitization to wearing medical equipment, hearing aids, glasses, CPAP, any of those types of things. I would actually say the highest referral is really related to challenging behaviors that kids are experiencing in a number of different settings. It doesn't have to be just at home, it could be at school as well. If there are questions or concerns around specifically autism, and then assessments, so being able to kind of qualify for services related to specific measures that are required for that. And then, of course, mental health being the other piece as well. The approach I will actually say that I take is I really try to think about things from the standpoint of like what are the current needs. So while we can categorize things into these different aspects that I've listed here, a lot of times it is really hard to actually label somebody as having a specific mental health diagnoses. Because challenging behaviors can happen for a number of different reasons related to communication, related to comprehension, related to, whether there are appropriate supports in a person's environment, related to, a number of things that are environmental that may not necessarily be that internal aspect of mental health, that occurs, influenced by external things. But it's sometimes hard to kind of make a concrete mental health diagnosis as a result, because a lot of times these things are happening because of those other situational aspects that we could address in a different way. And so we are going to spend some time today discussing what mental health issues present in people with Down syndrome, We're going to talk about prevalence rates or how often these mental health conditions occur within the Down syndrome population. We're going to talk about diagnostic criteria for a few of the diagnoses. We won't have time to kind of cover all of them, but really I'm going to hit the highlights and then share what types of questions to ask when meeting with professionals. So let's talk general information first. Mental health concerns can really be broken into two categories when we think about what we see most often. In younger or school-age children, we oftentimes see anxiety, we see disruptive behaviors, we see obsessive compulsive or repetitive behaviors. We might see mood lability that might, fall into the category of mood disorder. We might see aggression, again, a behavior, not necessarily, even something that is directly associated to a mental health diagnosis, but we might see some of that. Impulsivity, inattention, hyperactivity that might be associated to ADHD, autism, of course, and then sleep-related difficulties that also can present as mental health concerns. In adolescents and young adults, I would actually say that we probably see much more of like a clear diagnostic picture. So we see kids who and young adults who are experiencing depression, anxiety. It might be a diagnosis of obsessive compulsive behaviors or obsessive compulsive disorder. They might have sleep-related difficulties that are again impacting their mood, or their ability to concentrate or their ability to engage in their environment. And then sometimes we see a pretty significant loss of skills. Again, not a super common thing, but we'll talk about that as well. And so when we talk about prevalence, I'm going to share with you some of what the literature highlights at this point, but then I'm going to actually share with you why these numbers are not super duper accurate. Okay, so children and young adults with Down syndrome demonstrate increased non-pathological behavioral challenges, so 25 to 35%, compared to individuals who don't have Down syndrome or other genetic conditions, which might experience behavioral challenges between 5 to 25% through childhood and adolescence. When we use the term non-pathological behavior challenges, what we're really talking about are any type of behavioral challenges that don't fall into a specific diagnostic category. I would actually argue that most of the individuals with Down syndrome with whom I work really fall into this category. And I actually think that the 25 to 35% is probably an underestimation at this point. Previous studies suggest that children with intellectual disabilities are 3 to 5 times more likely to struggle with emotional or behavioral problems. It doesn't really identify why that is, but I anticipate that a lot of that is related to some of the other things that I have mentioned related to task demands, maybe not understanding what people are asking you to do, communication challenges, not being able to say how you're feeling or what you're needing. And of course, as you know, either from maybe talks that you've, participated in previously, or that you've even heard of, or the knowledge that you have, is that oftentimes when you have communication challenges or expressive communication challenges, behaviors are really how you communicate what is going on internally, rather than using the words to indicate that. And so it makes sense that people who may have more challenges with that would have more instances of behavioral difficulties or emotional dysregulation. In a study that we actually did when I did work for the C Center, we actually found that 94% of of children with Down syndrome engaged in behavioral problems for the population that we had evaluated. And I believe we had about 280 or so families that actually responded to this survey to ask, does your child have this specific behavior? And we made the list of behaviors based on our knowledge from professionals in the community that have encountered that when working with our individuals with Down syndrome. We asked how frequently does that behavior happen, and then how distressing or how much of a challenge does it pose. And we actually found, like, again, that 90%, 94% of those kiddos surveyed had some sort of behavioral problems. And what was really interesting, which ties into what I was just sharing in the previous bullet, was that this was significantly correlated with not just age, but also expressive language abilities. And so people who had more significant communication, expressive language challenges were the ones who really were exhibiting more significant behavioral problems. Then when we talk specifically about mental health diagnoses, so people who actually have had someone say, you have this mental health diagnosis, we see that children and adolescents with Down syndrome are more likely than their typically developing peers to struggle with externalizing behavior. So things like opposition, stubbornness, difficulty concentrating, inattention, impulsivity, attention seeking behaviors, speech problems. And again, you might say, well, these aren't all what we would call a specific mental health diagnoses, but these are the really the symptoms that seem to collectively result in what we call externalizing behaviors or things that are overt that then impact a person's ability to navigate their environment. And then at least half of all children and adults with Down syndrome face a major mental health concern during their lifetime. That's a pretty big number. We don't know what the duration is or what those diagnoses necessarily are, but that really this is something that can be of huge impact for our population. And then, while not all children who experience significant behavioral challenges receive a clinical diagnosis, some estimates would say 6 to 8% have a diagnosis of ADHD. I would argue that that's an underestimation. 10 to 15% have something called conduct disorder. 16% approximately with a diagnosis of autism, which is significantly higher than in the general population. 6.1 to 11.4 experience depression. And in intellectual disability, it's, between 1 to 2%. So there's a measure called the CBCL, the Child Behavior Checklist, that specifically, was used in children. And what they found was actually very high levels of, again, behavioral challenges that could or could not be connected to mental health diagnoses. So a low level aggressive behaviors, 63 to 76%. Preference for being alone, 63%, secretive behavior, 35%, stubbornness, 78%, disobedience, 73%, fears, 57%, impulsivity, 53%. So pretty high numbers there. And then on another measure called the BASC-2, when looking at adolescents, attention problems were 16 to 25%, social withdrawal was 10 to 17%. But really, in general, would say that mental health diagnoses are 18 to 23%, where they may have some sort of significant mental health challenges. Now, if your head is spinning and you're going, man, you're giving me all kinds of percentages that are not consistent with something that you said on the previous slide, you are correct. The reason for that is because there's lots of inaccuracies of prevalence rates, and there's lots of reasons for that. One of the reasons is because in a lot of these studies, individuals with Down syndrome were being lumped in with other genetic conditions that may also have intellectual disabilities. And then when we actually like break it apart, and there have been some research studies that have separated people with Down syndrome from people with other types of genetic conditions that have intellectual disability, they actually found that there was a difference between those that had Down syndrome versus the other genetic conditions with intellectual disability. And so if you're lumping two groups together, it is really hard to then be able to know how accurate the prevalence rates are. The existing measures that, we use sometimes to help us make a decision about a specific mental health diagnosis are really, not always validated for people with Down syndrome. And so there's some measures like the CBCL that I mentioned in the slide before that have been looked at and have been said, it's fair. Those are, good things to use as measures in people with Down syndrome. But the vast majority of the time, people are making a clinical diagnosis based on symptom presentation and not even using a specific measure because they are not validated with people with Down syndrome. And then we have something called diagnostic overshadowing. This is a fancy term that's used for a lot of different categories of individuals or a lot of different populations. But what you're really doing is you're saying that a person is experiencing whatever challenge that they are because they have Down syndrome, because they have a language impairment, because of their intellectual ability, or because of other aspects of their developmental delays. And so sometimes mental health issues really get missed in our population because people are saying, oh, those are just things related to having Down syndrome versus saying, actually, you can have Down syndrome and you can struggle with a mental health condition. And so our numbers, again, our prevalence rates are all over the place because of that. And then we have to take into consideration neurodevelopmental factors that are associated to Down syndrome. So we know that we experience delays in our impulse control or delays in our attention span as a result of how the brain develops in an individual with Down syndrome. Again, that doesn't necessarily mean that the person doesn't have ADHD as they get older, but what it might be is that we are kind of constantly navigating and negotiating where they are developmentally and if that's typical for what you would expect, right? So we wouldn't expect a 2-year-old to sit and pay attention for 30 minutes to, a lecture on, physics or something like that, right? Like it doesn't make sense to have that attention span at that developmental level. So we are constantly contending with, is this what, really matches? Is their attention ability? Does that match where they are developmentally, or are we really looking at something that is impacting them in a negative way that really could be more associated to something else? Same thing with like anxiety. Is this anxiety because things, I'm missing pieces of information in my environment because my comprehension skills are impacted, or is it that I really am constantly experiencing a heightened level of anxiety? And so it just really makes it difficult for us to have accurate prevalence rates. And then the final thing I would say is that there's a difference between behavioral challenges and psychiatric conditions. I would actually argue that there's a lot of times symptoms can overlap between the two, but behavioral issues really can be addressed with just behavioral interventions most of the time. And there's something environmental, again, is really exacerbating the presentation of these symptoms. Whereas if you're thinking about psychiatric conditions, they can be highly influenced by family history of psychiatric conditions or mental health concerns. They can highly be impacted by like mood lability, right? Like, so the person is not experiencing mood changes because of something that's happening in their environment. It's really a lot less predictable. And that is something that has to be addressed a little bit differently. And so let's talk about a little bit of specific diagnostic criteria. There is actually a manual that I would highly encourage you to ask your providers to look at or access when thinking about mental health diagnoses in people with Down syndrome. So we have this thing that you may have heard of called the DSM-5. And that manual is actually a book that helps you descriptively look at what do mental health diagnoses or psychiatric conditions look like in people who don't have an intellectual disability. So many years ago, they created something called the DMID, the Diagnostic Manual for Intellectual Disability, to say, you know what, for people who have an intellectual disability or people who have a difference in how they're able to navigate and process information, that those folks actually might look a little different in their symptom presentation when we're thinking about mental health diagnoses. So I would actually say we don't have a diagnostic manual for Down syndrome, but to me, the diagnostic manual for intellectual disability is much more closely associated to what things we would be considering as clinicians when we're thinking about or considering a mental health diagnosis for individuals with Down syndrome. And so let's talk, about kind of the big categories that we oftentimes see in our population. So let's start with anxiety based disorders first. So PTSD, when we're thinking about it in the context of Down syndrome, what does that really look like? So what we perceive or what we see is trauma-specific enactment. So if they've experienced a trauma, they might reenact that trauma over and over and over again and kind of even get a little bit stuck with that. So rather than being able to verbalize and say, this is what happened to me and I can't stop thinking about it, you may see actually a reenactment that is reflective of what happened versus a verbalization of it. We might see disorganized or agitated behavior that doesn't seem to, kind of match the situation. We might see people avoid things that, might look like non-compliance, or, people might say, oh, they're just stubborn, or they just, are doing that because they don't want to do what we're telling them to. They're just refusing. But, it is really important to consider, did something happen in that context, especially for our folks who have a harder time with articulating something that may have happened. We oftentimes see a loss of interest. I mentioned acting out, but that might be, acting out the specific trauma, but it also might just be acting out by hurting themselves. They might be disorganized. They might be aggressive towards other people. So it might actually escalate past just the agitated behavior and get to the point of actual aggression. Um, some of our kids who do have the verbal ability might be verbalizing their fear or avoiding certain situations or certain places for unknown or unclear reasons. And I'm sharing these things with you not to kind of make you panic and say like, oh my gosh, if my loved one has one of these behaviors or one of these symptom presentations, then I should be really, really worried. What I'm saying is that when we see any of these things, we should get curious. And curiosity will then lead us to kind of determine whether or not we need to do something about it, or if there is something that we should really be concerned about. Obsessive compulsive disorder, this is actually one I get asked about a lot. In the Down syndrome phenotype, oftentimes we see kiddos who kind of want to adhere to certain routines. They get really, they might get upset if the routine is changed or if an expectation is changed. For some kids with Down syndrome, I actually argue that the vast majority, that need for sameness is actually more related to reducing their anxiety and feeling like they can actually do the thing that other people are asking them to do. So if I didn't know what the expectations were in a situation, I would get anxious and then I would feel like, oh my gosh, I'm failing all the time. Whereas if the routine stays the same, I always know what I'm supposed to do and how I can successfully accomplish it. And I don't have to worry about what pieces of information I'm missing. So it's important to really distinguish between what we call anxiety-based repetition or competence-based repetition versus what kind of then gravitates towards something much more significant like obsessive compulsive disorder. So what we think about in this context is recurrent and persistent thoughts or urges that may not be experienced as distressing. So obsessive compulsive disorder is actually has two components. It's obsessive thoughts and then compulsive behaviors. Sometimes the obsessive thoughts are actually really hard for us to see, right? Because maybe the person is not able to articulate what that is. And so they might not even, or they might not necessarily be aware of the fact that that thought is distressing. And then, and so that symptom is not going to necessarily be there. For our population, we more oftentimes than not see the compulsive side of things. So a need to do something over and over and over again. They might not necessarily be able to share or may not attempt to ignore or suppress thoughts. They're actually just doing these repetitive behaviors. Importantly, interfere with their ability to move on. So we're not talking about somebody who, needs to close the doors before they walk out. It's the need to repetitively do that, or the fact that they can't move on from that even when something better is coming along. So that's really important to make that distinction. Generalized anxiety disorder or anxiety NOS. So what it looks like in Down syndrome, refusal to engage in certain situations, repetitive question asking. So sometimes, I've had folks who will tell me, oh my gosh, they ask the same question a million times. And what we want to think about is like, what's the function or purpose for that? Is it that they really don't know the answer, or is that something that actually helps them to reduce their anxiety in the moment? We might see behavioral changes in certain environments, or we might see significant tearfulness. Next, let's kind of go into the category of mood disorders. And I will warn you that this presentation is really giving you an overview, but my hope is that at the end, I can leave you with really good questions that you can ask yourself, that you can navigate when, talking to professionals, that will really help you whittle down what it is that might be going on with your loved one if that's something that you're concerned about. But again, you're going to hear me keep saying, get curious rather than panicking, get curious about what might be causing some of these symptoms. So mood disorders, we think of these as depression, bipolar, disruptive mood dysregulation disorder. Those are kind of the highlights that we see within our population. But again, bipolar in particular is pretty low prevalence rates. But as I mentioned before, we aren't really great at calculating what that is. So I really like to think of it as what is the individual things that we need to consider in this moment for this individual person that helps us to determine if their symptoms are negatively impacting their day-to-day life. So, what does depression look like in individuals with Down syndrome? We might see depressed or irritable mood. The person may have lost interest in things that they previously really enjoyed doing. We oftentimes see weight loss or weight gain, so a person losing interest in eating or eating all of the time. Changes in sleep patterns, those are all those first four bullets probably are all things that you would actually see in a population of people who don't have Down syndrome as well, right? One of the ones that we see that actually is different for people with Down syndrome is an increase in self-talk. And the nature of that self-talk is really important too. So it might be, saying mean things to themselves. It might be repeating things that they've heard from other people that are very negative in nature. And so it kind of has like this dampening effect of the self-talk. It's not a cheerleading type of self-talk. It's really like, reflecting feelings of worthlessness or not feeling good about oneself. The person might be less active. Rather than just saying, oh, I don't want to do that, we actually see skill loss. So don't worry. If a person's depressed, it doesn't mean that there's that skill is lost completely. It's just that they're not demonstrating it anymore. So maybe they were getting up to shower and, able to do that. And now they are refusing to do it. And it doesn't mean necessarily that they have lost that skill completely, but it might be that they can't access the information in their brain in order to be able to complete it successfully, or they might just not have the level of motivation to complete it either. The one other thing that I would argue is a little bit different in depression for individuals with Down syndrome, and I would actually argue even young, very young children who don't have Down syndrome, is that depression can be reflected in disruptive behaviors. So really tons of refusal, an increase, a change in behavior related to that. For bipolar, what it looks like in Down syndrome is agitation, tearfulness, grandiosity, which means kind of like, I can do anything, a decreased need for sleep, increased activity, so just really not ever being able to turn yourself off. Oh, I have decreased need for sleep twice on there. Apologies. Pressured speech, so really for our population, it might not be, pressured speech in full sentences, but it might be like, even tumbling over their words and not being able to articulate fast enough, but then not being able to stop that communication level of communication either. Might be really, really distracted kind of all the time, maybe like quick movements related to that, and then hypersexuality. This one's really hard for me because I feel like the hypersexuality is really hard to define. I think that sometimes for people with Down syndrome and even other disabilities, we forget that individuals can still have a desire to, you know, um, be sexually active or to have a sexual relationship. And so that's not necessarily hypersexuality, but might be interpreted that way because the person maybe doesn't have the best boundaries with kind of recognizing what is appropriate in one situation versus the other. So it really takes a lot of digging and asking additional questions to be able to determine if that symptom is actually present. Disruptive mood dysregulation disorder. I actually think that this is an interesting diagnosis because it's oftentimes used as kind of a catch-all. But in Down syndrome, it is reflected by like temper outbursts. So temper tantrums that are not like developmentally related. And so you'll see that it's really before the age of 6 or after the age of 18 that we're thinking about this. But it's basically like, I cannot regulate myself ever. It's not one or two temper tantrums along the way. It's like persistently irritable or angry most of the day, and that irritability and anger sometimes results in a temper outburst, and then sometimes just as this like low grade irritability and anger as kind of their baseline. The next category is executive function disorders. ADHD is actually a hard diagnosis for a lot of people, but it is a high prevalence for people with Down syndrome. Within our population, what it looks like is inattention, hyperactivity, impulsivity in two or more settings, not including school. If you know anything about ADHD in the general population, that's actually very fitting with what diagnostic criteria we look at for people who don't have Down syndrome. So it actually looks the same. The biggest thing that we have to take into consideration is it developmentally appropriate for them to be inattentive, hyperactive, and impulsive? Think toddlers, think, really young children, or is this something that feels above and beyond what we would anticipate? One of the things that myself, other psychologists that I know, other psychiatry colleagues that I know that specifically work with people with Down syndrome, we oftentimes think about is how much is it impacting their ability to navigate and access their learning environment? And so safety becomes a huge part of that. If their impulsivity and hyperactivity is resulting in people being so unsafe that you're worried, it is probably a really good idea to think about whether ADHD might be present or not. And for all of these diagnoses, if there is a family history for it, even though our friends with Down syndrome have an extra chromosome 21, we still know that genetics still pass down, and that if there is, a family history of these mental health conditions, that they can be passed down to our kids, and that there might be a more likely to actually be presenting with that as well. Autism, what it looks like in Down syndrome. You're going to see me with a lot of slides for this one and for Down syndrome regression disorder. But what I want to tell you is that I'm going to share with you kind of the highlights, but also tell you that autism and diagnosing autism in Down syndrome can be challenging for people, again, because of that diagnostic overshadowing and saying, oh, these are just features of having Down syndrome, and not recognizing that they actually could be really related to a secondary diagnosis of autism. So, what it looks like in Down syndrome, rare attempts to imitate others. People with Down syndrome are actually really great imitators. So, if you're seeing, not a lot of attempts to imitate, again, that doesn't necessarily mean that your child has autism. It could also be really developmentally related, and whether their developmental skills are much lower than what we would anticipate for when we develop the skill to be able to imitate. But again, something to take into consideration. The tendency not to share emotions by directing their facial expressions to others. So maybe when I'm smiling, I'm not actually looking at a person or a communication partner in that process, where I'm telling you this is what I'm feeling versus kind of just sharing it to the world. Um, a disconnect, so between the child's emotions and what's going on around them. So really being happy when the environment is sad, or really being sad when the environment is happy. A lack of understanding about the process of communication, so a lack of intentionality. So an example I give is like a child who's standing in front of the refrigerator signing milk, but not actually, but there's nobody around to actually see, hey, I am asking for milk, right? So the person's waiting for somebody to just, incidentally see that that's the request, versus going up to a person and signing milk to that person, knowing that that person is who can get that for me. Um, Social communication and orienting skills that are below the child's other skills. This is so important. So many people will say, I think my child has autism. And what we have to point out is that there has to be a discrepancy or a difference between their social communication and their orienting skills compared to all of the other skills that they have. If all of their skills are at the same level and they're having challenges with social communication, that's not autism. That's much more related to their intellectual ability and what might be going on there. And so, again, we have to make that distinction. Other things that it looks like in Down syndrome, a lack of shared enjoyment with others. So not trying to like show you things that they are excited about, or wanting to bring you in. Few attempts to communicate verbally or non-verbally, so not using gestures or anything like that. We oftentimes see unusual vocalizations without like functional communication. So it might be like making kind of a monotone, repetitive sound. in some kids, we see a change in functioning. So a third of kids with Down syndrome lost language alone, and that loss occurred at 44 months. And then a half lost other skills, that they had already acquired. And that loss occurred at 27 months. So there is, some kids who kind of show signs of autism from a really early age, but then there's a small portion that also we think have, a loss of skills that really then becomes more pronounced in the aspect of autism, and when there's not another explanation for it. And then you may have heard the term regression or Down syndrome regression disorder. This is really thinking, older adolescence and young adulthood. But regression is a term for the loss of previously acquired skills that they've developed. And it can be anywhere in the context of daily living skills, language, motor functioning, or social interactions. The regression can occur slowly over weeks or months, or it can happen really, really fast. And the time course typically can help us determine the likely cause of the regression. But what I will tell you, having just completed a clinical trial for Down syndrome regression disorder, is that we really don't have the answer for what causes it, and that is part of what we're trying to figure out so that we can really do more individualized treatment intervention, based on what we think might be the trigger. It can be caused by many things, but it's really associated with like a dramatic decline in functioning, from what skills they had previously. So some people get worried because our kids do sometimes fluctuate in their skills. So they might, show some progress in potty training, but then slide backwards, or they might, be doing something in their social environment that they kind of have stopped doing as much of. That in and of itself does not equate Down syndrome regression disorder or what we really call regression. When we're talking about regression, it is so dramatic that we feel like it is an emergency, right? Like that we can't engage with the person at all, and that we kind of have this like panicked aspect of like what just happened. So I think that that's important to kind of distinguish as well, because I know that Down syndrome regression disorder is being talked about so much in our community right now, which is wonderful. But I think that it is also causing some distress to families, where maybe that's not necessarily the issue. So what it looks like in Down syndrome, it's rare, but increasingly being identified. The age of onset is typically in adolescence, as I mentioned. It is not autism. We've actually had lots of people who have said late onset autism, but it's not autism. And I think it's important to make that distinction because we do know that Down syndrome regression disorder has clinically treatable options, and we don't want to miss the opportunity to try some of those things. The onset is rapid, it's treatable, and the prognosis is really variable. So some people recover completely, some people are back, to baseline, some people recover 80%, 25%, 50%. We just don't have all of the answers quite yet. And so when I'm doing an assessment related to differentiating between a behavioral challenge versus kind of something that would be really, really important to identify as a mental health condition, I really start with gathering historical information. And the types of things that I ask are, when did the symptoms start? How severe are the symptoms? Remember how I mentioned that lots of us have kind of some compulsive behaviors. There's a little bit of OCD, a little bit of anxiety, a little bit of depression, but there is kind of this bar that it has to reach where it's really negatively impacting our day-to-day functioning and our ability to navigate our environment in order for it to kind of lead to something that we more significantly would call a mental health condition or a psychiatric condition. So you'll see I ask about severity, about the impact. I do like to ask about possible triggers. So did anything happen? And a lot of times families will say, I don't know. And what I'll say is, let's just do a little investigating. Who are the people in, your loved one's life that we can kind of do a little bit of curiosity detective work with, to be able to see, did they see anything? Did they notice anything? What, did they see that change happen specifically in an environment, a specific environment? And then it's also really, really important to get a medical history. What we know is that mental health conditions or medical conditions can mimic mental health conditions. For example, hypothyroidism, which is a condition that many people with Down syndrome have over the course of their lifetime, actually can look like depression. Because it is related to your hormone levels, right? So one of the things in the general population that we oftentimes do is we check when people present with depression, we check their thyroid level to see if that actually might be the mode of treatment rather than it being a psychiatric condition. So we, knowing that we have a higher prevalence in our Down syndrome population, we want to make sure not only do they potentially have a diagnosis of hypothyroidism, but also are there medications, appropriately treating it? Because the depression might be, a byproduct, or it might just be mimicking that specific medical condition. We also know that like irritability, aggression, those can all be related to somebody who has obstructive sleep apnea and they're not able to get a good amount of sleep. So we want to make sure that we're asking questions related to that too. And again, we're not saying like that, okay, we just treat the medical condition and then the symptoms go away. But man, wouldn't it be great if we could identify that as the underlying reason why symptoms were presenting? Because then we're actually targeting the right thing to treat. If we just call it depression and we don't look at thyroid levels, for example, we might end up unnecessarily putting somebody on a bunch of psychiatric medications that they don't need to take. And so we want to make sure that we're really doing kind of that, our due diligence with finding out that information. As I mentioned, family history is a big piece as well. If you have a family history of mental health conditions, it is absolutely something that could increase the risk for your loved one with Down syndrome. I typically do some formal measures, and they're, oftentimes questionnaires that caregivers will fill out. To me, I don't use those for in isolation. So I don't say, oh, you scored this, so, and that's past the cutoff, so you have this diagnosis. I use it as, again, evidence or information building. And sometimes it's easier to gather information in a questionnaire format related to very specific symptoms than to spend, the time, or even if we don't have the time to be able to gather all that other information. So sometimes I'll actually send out questionnaires ahead of the appointment, and then I'll look at those in preparation for the appointment so that I can, ask additional follow-up questions if necessary. Observation is really, really powerful. And so being able to observe the person with Down syndrome in an environment, it's actually kind of funny when families come in and, their child is behaving in a certain way. I will ask, like, is this typical of how they are, when they're at home or when they're out in the community, or is this really different? And that also is going to tell me, is this just kind of like how they're acting because it's a new situation in a new environment and they're excited to be there? Or is this really like reflective of how they would look in other situations too? I actually also love, love, love looking at videos of kids outside of the appointment. That's such an easy way. Most of us have smartphones and are able to kind of grab videos here and there, and are doing that with in other environments, at the playground, at school, at grandma's house, or wherever. And that can actually be really, really helpful. And again, creating a full big picture of what is going on. And then I really think about neurobiological factors that increase risks. So we know that our kids with Down syndrome oftentimes have an underdeveloped frontal lobe, and your frontal lobe is responsible for impulse control, emotion regulation, inhibiting your impulse to like do something unsafe, any of those types of things. So we have to really think about, are there factors that are developmental that we need to take into consideration as well? So visual memory falls into that category. And then I always say that it's important to have specific questions to ask providers. So, and to ask ourselves, how are the symptoms reflective of developmental level? So remember how I told you about ADHD and we were talking about, is this really ADHD or is this just really where they are developmentally? And because there's a discrepancy between their age by birthdays and their developmental age, is that kind of what we're seeing? Or is it really something more reflective of a mental health condition? How are the symptoms impacting day-to-day life? Such an important question. If it's something that you feel like we have to do a little bit of adjustment, or, when I ask them to transition from point A to point B, they might put up a fuss, but then we're able to do it. That's not a mental health condition. A mental health condition is when they become so dysregulated and so overwhelmed that you really feel like you're changing your whole approach to life in order to be able to reduce the instances of that behavior. So I've had families who have said that their loved one with Down syndrome is really anxious or gets overwhelmed when they go out in the community. And for some people, that's manageable. They wear noise cancellation headphones. They, still go out. They maybe plan, activities so that when they're at the restaurant, their loved one with Down syndrome has other things to do so that they're not impulsive and doing unsafe things. But then there's families who tell me, like, we've just stopped going to those environments completely and it's really miserable. And that's when I kind of go, whoa, that is impacting not just the child's day to day or the person with Down syndrome's day to day life, but now it's impacting kind of the people who are around them as well. And if we're really accommodating to that level, we do need to consider other things as well, potentially a mental health condition. Are there safety concerns that need to be considered? This typically is one of the number one reasons why families end up actually coming for even a mental health evaluation because they're like, oh my gosh, they're so impulsive that I'm so worried that they're going to end up hurting themselves or they have hurt themselves. So this doesn't mean like, the vast majority of our kids when they're really young actually have safety concerns in the sense that they don't necessarily understand something is unsafe. So maybe like they're, trying to touch the stove. That's a little bit different. Obviously, we don't want them to touch the stove, but then if you're able to redirect them or find other ways to kind of prevent them from doing that by supporting, like having covers on there, having locks on, the dials, things like that, and that works, great. But if the persistence of those safety concerns keeps happening, then we want to think about it a little differently. How are the symptoms impacting growth and development? To me, oftentimes there can be the presence of certain mental health conditions, but until they're school age or entering into other environments outside of the home, we may not see the impact of how badly is it impacting their growth and development. And then for young adults and adults, if they're not no longer able to engage in their day program or they are really struggling at work, that is really impacting their growth and development and their ability to sustain what is kind of their peak performance. And so that's something that we want to make sure that we're asking ourselves too. Okay, that includes all of my slides. I want to make sure that oh yay, 10 minutes for questions. Um, if you want to just unmute yourself, if you want to, you know, uh, turn your camera on, let's just make this, it's a small enough group that we can actually just make it a conversation, if that works. Man, I answered all the questions? Fabulous. I thought I had seen no questions, but appreciate the info. You're very welcome. Lori, I know that you were on your way to a funeral. I'm so sorry to hear that. But it seemed like you had a question that you wanted to ask. Are you in a place where you can ask? I'll take that as a no. Whitney, I will send you a PDF of the slides. The slides I intentionally made a little bit boring in the sense that it's a lot of information on each slide. But the reason I wanted to do that is because I want you to be able to go back and reference it and say, huh, I'm really worried about depression. In Down syndrome, what does that look like? And then go to that page and then be able to kind of go through and say, like, am I noticing any of these things? Or not. And so I do think that that's actually a really good way to be able to then know if you need to go to a primary care doctor or see a specialist to be able to actually determine if, a mental health condition is something that you need to treat or need to address in a different way from kind of some of the behavioral strategies that we talk about on a day-to-day basis.
Okay, that would be great. I'll definitely share with everyone that registered. So we so appreciate you
Yeah.
doing this presentation. So informative. So thank you so much.
Thank you guys for all joining. Please reach out if you have questions. Whitney has my contact information. And thank you again for the opportunity.
All
Have a
right.
great rest of your day.
You too. Thank you.
Bye-bye.